All right, welcome to the Social Justice Research Seminar. This week, I am very happy to have Dr. Zappas here with us. She is one of our nursing faculty and is going to be talking with us. I'm not even going to try to pronounce that. I'm going to do it terribly wrong. But you are going to be talking about maternal fetal nursing, which is very cool. So I'll let you take it away.
All right, thanks. Yeah, so thanks everyone for showing up. We are gonna be talking about congenital cytomegalovirus and the knowledge that nurses have about the virus that work in the maternal fetal setting. Okay, so cytomegalovirus is a pretty common virus, and normally it gives us like a little bit of a cold, right? So people who have healthy, robust immune systems, it is nothing that big of a deal. And most people are infected within their lifetime. The virus is actually a herpes type of virus, which as other herpetic viruses, it does have latent and reactive properties, which means that it basically kind of integrates itself into our genome and can kind of be suppressed and then break out. So harmless in adults with a robust immune system, and generally the only two subset of patients or people that we worry about this with are patients who are immunocompromised because of HIV. It is considered an opportunistic infection, and pregnant women. So it is actually teratogenic in pregnancy and is transmitted through close contact, like saliva, urine, breast milk, things like that. Very similar to any other sort of common cold-like virus.
Michelle, is it a challenge also for infants, for young children, CMV?
Yeah, but generally it is actually pretty common in young kids, just generally as their immune system is growing, they get infected with it. The effects that I'm going to talk about with a young kid is not going to have that sort of effect. It's more because when the pregnant woman is infected with it during fetal development, it actually is where it gets to have the problem. So here it is, right? So the pregnant woman becomes infected with this virus, and again, kind of for her might feel like she has the common cold, but the virus actually will cause an inflammation of it's velitis, which means the vasculature or the blood supply to the placenta. And with that, it sets off sort of this inflammatory chain reaction that will impede the nutrient and gas exchange, right? The fetus placental vasculature is what allows the fetus to get our nutrients, oxygen, even all of that sort of gases and nutrients. So this is one, and I'll look at, I'll show you guys the other ones, but it's considered a torch infection. So there are a bunch of infections in which this same sort of pathogenesis can happen when a pregnant woman gets infected with it. So so these are like inflammatory responses, and basically ultimately we get some cell death and inflammation there. Only 10% of babies born with the virus actually will show symptoms at birth. And this little kiddo here has petechiae, which is sometimes called the blueberry muffin rash. This one is showing us hepatosplenomegaly, right? So an enlarged liver and spleen. This kiddo also seems to be a little jaundiced or a little yellow. And then this is a picture of microcephaly. So that just means a small head, and particularly the small head in relation to the rest of the body. And intrauterine growth restriction, again, is just kind of this catch-all term for a inability for a fetus to grow properly during utero. And so they often come out, these little babies come out very small. So 10% show symptoms at birth, right? Which means that 90% of babies that are born will not show symptoms, right? So they are considered obviously asymptomatic. However, regardless of whether or not the child is symptomatic at birth or asymptomatic at birth, hearing loss can occur. So sensory neural hearing loss, which is SNHL, and it's the leading cause as opposed to genetics or something like that. It is the leading non-hereditary cause of hearing loss. So 1 in 3 of those symptomatic kiddos can have either hearing loss at birth or what's called like a delayed progressive hearing loss. So it can, over the first couple of years, they can start to lose their hearing. And in the asymptomatic children, 1 in 10 are infected with hearing loss. So this is probably the biggest sort of long-term sequela of this virus. However, there are also a lot of other complications that can occur. It is associated with cerebral palsy, which is just really an umbrella term for brain damage in utero or in the first couple of years of life. They think that there is a link between ADHD, or there's maybe even a link between autism, spectral disorder, and things like that. And then this one is vision impairment. So this is a classic, this is chorioretinitis, or basically an inflammation of the retina. And so you can see this is necrotic damage, right? So the black part is the necrotic damage, and then the white part is, well, actually also damaged. And then that is a hemorrhage. So that's a little bit of blood. And sometimes it's called the pizza pie. So, which kind of cracks me up that there's blueberry muffin baby and pizza pie eyes, with this, but anyway, so these are some of the long-term complications that can occur. But again, hearing loss is number 1. So this is the C in the tort infection. So toxoplasmosis, syphilis, Zika, mumps, varicella, rubella, cytomegalovirus, and then just even herpes simplex virus are considered torch infections, which is, again, a group of infections that don't cause much damage to people with healthy, robust immune systems. However, can be teratogenic to fetuses. So toxoplasmosis, for anybody that's been pregnant, we are usually told to avoid cat litter. And that's the one that comes from cat litter, toxoplasmosis. Zika, we all know about because of that 2015 outbreak that occurred, and that they were linking that one to microcephaly and a lot of other sort of similar sort of symptomatology. Rubella, this is actually congenital rubella syndrome, is very, very damaging to the fetus. And this is why we have the rubella vaccine, right? So the measles, mumps, rubella vaccine, rubella, as opposed to measles, gives us a cold, right? Measles can actually be very life-threatening and dangerous for people to get that are, even with robust immune systems or younger children. But rubella doesn't. It's the same sort of idea of a cold. However, it's very teratogenic. And so this is one of the reasons why the rubella vaccine came into play. So this is a slide from the National CMV Foundation about the disproportionate awareness about this virus. and disability, right? So it's one of the leading causes of disability in children, right? So you can see this little orange dot over here in the number of children disabled by this condition every year versus the number that have actually heard of it. And so, for instance, you know, HIV, congenital HIV and AIDS, well, a lot of us have heard about it, but yet that actual vertical transmission of that virus is pretty low for a variety of factors, which is good. Okay. So vaccine, there is a vaccine in the works. It's currently pending with Moderna. And then if this virus is identified within the first 28 days of life, a child can get an antiviral that will help. However, the antiviral obviously is going to have a lot of side effects, and not every child can tolerate that. So really what a lot of, you know, what can be done is early identification, diagnosis, screening, and intervention. And particularly since hearing loss is a big component of the congenital CMV or congenital cytomegalovirus, you know, it is early diagnosis and intervention can really help with language development and communication development and social development and all of those sort of things that go along with that. So increased screening may allow for early diagnosis and intervention and better outcomes, right? All right. So this is from 2024. And as of 2024, there are 21 states with either screening or education laws. When we did this study, there were only 18 states. So I'll just, this is just to, you know, kind of show you. So some states have mandatory screening for congenital CMV at the time of birth. Some states do sort of a reflex testing. If the baby fails the newborn hearing screen, then they'll test for it. You know, so they're varying different sort of recommendations or laws that obviously vary state to state. So, and this is pretty big, screening or education laws, right? It's pretty big, even to begin with. So what we did is a study to evaluate the knowledge and awareness of congenital CMVs of nurses who specifically work with infants, right? So neonatal nurses, maternal nurses, nurses that are working in that area, in that arena, to see if they have an adequate understanding of the symptomatology. And well, I'll get to that, I guess. I'll show you guys that. So this was actually, we did this study, we kind of adapted it for nurses. So this was an original study that was published in the Journal of Primary Care and Community Health that Dr. Pesh and Muldoon did about primary care providers' knowledge and newborn hospitalist knowledge in the state of Michigan, where there was, at the time of this study, no screening or education laws about it. And so just kind of looked at what the baseline knowledge of, again, these providers that are coming in contact a lot with, you know, pediatricians and newborn hospitalists and things like that. So might have exposure to kids with congenital CMV. So what we did is we adapted that survey to nurses, and then we sent it out to nurses working in maternal, fetal, and neonatal health. So we got in, we basically got some email lists from AWON, which is the American Journal of Women's Health and Obstetrics, and we were able to send the survey out. It is, yeah, so the eligibility, I mean, in like boiled down eligibility, nurses, so you had to be a nurse, you had to be actively working in maternal, fetal, neonatal health, and you had to be in a state at that time, right? There were only 18 states with laws, so we had to be in a state that does not have laws, where screening is not standardized. But you could be a BSN, MSN, doctorally prepared, you know, that didn't matter. We did get some funding for this from the National CMV Foundation. And so we were able to incentivize, you know, responding to the survey with a little gift card. And this is one of the founders of National CMV. Her child was affected and I think ended up dying from CMV. All right, so we sent out 1,000 surveys and 215 people completed the survey. And we, you know, did a data analysis. So I'll show you the results that we got. So this is also there, the survey was pretty long, but for the purposes of even the publishing that we did and this little talk, we really boiled it down to look at just a couple of questions. So again, the original study was also taking into consideration whether or not somebody is like screening for it or what their practices are in terms of congenital CMV. And, you know, this was really a limitation of the study because that doesn't really translate very well into our nursing population. So what we ended up really being interested by was, do nurses know the prevalence of this? And do they know the symptomatology and the long-term sequelae of this, right? So how common is CMV? You know, there were 1 in every 100, 1 in every 200, 1 in every 500, or 1 in every 5,000 live births. And this actually, the nurses did better than the physicians in Michigan about the prevalence of it, but still pretty low in terms of percentage. Only 31% of participants got that correct. But I believe it was like 22% of the PCP and newborn hospitalists. What signs may be present at birth in a newborn with CMV? So elevated liver enzymes, hearing loss, jaundice, low birth weight, microcephaly, petechiae seizures. So we kind of went over that, right? Petechiae rash, that's the blueberry muffin baby. Microcephaly, you know, the little head. The intrauterine growth restriction, again, causes usually a small for gestational age child or a child with low birth rate or weight, despite being full term. And then we also have 90%, remember, of infants that are actually born asymptomatic, right? So that was also an option there. What I found interesting is that nobody got the microcephaly one. And again, I find this interesting because, you know, again, there's not much that is known, I think, about CMV, and that was kind of part of this study, obviously. But we have heard about Zika, right? I mean, virtually a lot of people, because of that 2015 outbreak in South America, a lot of people have heard about it. And again, this is part of that umbrella of the torch infections. And a lot of them have the same sort of presenting signs and symptoms. And so I thought that that was kind of interesting that, you know, despite that, there wasn't that sort of connection with, oh yeah, this is a torch infection. And I know that other torch infections can cause microcephaly. So anyway, that was interesting. And then, what else? Yeah, I mean, a lot of a good number, well, 61%, you know, of participants knew that it could be associated with hearing loss and intrauterine growth restriction, so small for gestational age. But I thought the no signs was also somewhat low. which is true of infants born with asymptomatic congenital CMV. So at increased risk of hearing loss at birth, and then also hearing loss later on in childhood, but 47.9% of respondents did answer that correctly. 34% did not answer, and that was kind of one of the things that we were finding with it. The survey was a little long and we were kind of losing, I think, some interest in people, a little survey fatigue there. So that was maybe part of that, or maybe, you know, they didn't know, but didn't want to put, I don't know. All right, so overall, we looked at about 10 factors, right? Prevalence, signs at birth, and then long-term, or signs at birth and in association with hearing loss. And our mean was that these nurses scored a 3.39 out of 10. Max was an 8 and min was a 0. So that is led us to believe that the knowledge, there's a lot of knowledge gaps in maternal fetal nursing with regards to congenital CMV. So this Spearman-Rowe correlation didn't really turn out. There wasn't really much of a correlation between whether or not somebody knew about it versus, you know, interest in knowing. So that was a little bit all over the place. But we did see, you know, there was some pretty significant knowledge gaps in the symptomatology. And that is a little disconcerting. If you think of one of the roles of the nurse is to monitor the patient and notify the, you know, prescribing or provider who's putting in the orders, like, hey, you know, we should probably look at testing this child for, you know, CMV or something like that based on X, Y, and Z. And so a lot of nurses didn't really have a good understanding of all of the symptoms related to it. So ultimately, we conclude that there is some need for educational efforts and training or more information during BSN programs, MSN programs about this virus due to its, you know, it's common, it's often overlooked, and it really is one of the leading causes of disability in our pediatric population. So I'll stop sharing here, see if anybody has any thoughts or questions. Yeah.
I have one. So thank you so much for this. I think I'm really struck by the gap in knowledge, and I'm wondering if sort of, I'm trying to think about how to articulate this question. I'm wondering about, is this a relatively newer, is the understanding of this disease relatively newer, and to what extent does this lack of knowledge have to do with sort of where people are in terms of like when they were trained? Because I think when I'm looking at the slide that showed what the general population knows, it really struck me that this is as problematic in terms of how much it impacts kids as Down syndrome. And everybody's heard about Down syndrome, but nobody's heard about, you know, CMV. And I'm thinking, well, I don't know that I had heard of CMV. And so I'm wondering, you know, is this a because it presents as the common cold, 1 in 10 babies, you know, are asymptomatic when they're born. Like, to what extent is this something that is a relatively newer like
Yeah.
the etiology and the description of the
Yeah.
disease and the awareness in, in the medical community, or is it just that because it's kind of invisible, it's always been under the radar?
Yeah, it's more the latter.
Really?
It has been a virus that has been known about for a pretty long time. Most providers really think of it as not something that is that big of a deal. In fact, that is some of the policy and the advocacy that is going out about just education and screening nationally, is that, oh, we don't have time to screen for this, we don't have time to educate our patients about this. It's not that common or common enough. And I think also the fact that it is asymptomatic in 90% of kiddos, and then yet those kids are still, have a little bit of a higher chance of becoming deaf. It's more they don't really believe that it's that big of a deal.
That's true. And the follow-up question to that is there, I mean, antiretrovirals is a relatively new approach to there've been antiretrovirals for like HIV since the 90s.
Yeah.
So I mean, I know antiretrovirals in the grand scheme of human history is very new, but maybe in the medical field, it feels like they've been around for a while. But I mean, is also part of this that in earlier decades, there was not much you could do about it also. And so is part of it that there's, with a vaccine looming, antiretrovirals are increasingly like a thing, that there's now something that you can do for it? I mean, it just strikes me as being, I'm flabbergasted that something that impacts this many people is so unknown.
Well, and honestly, I'm flabbergasted by it too. And that was kind of the exact purpose of this study, was to just show that there is a big disconnect out there in public health awareness, and I really don't know exactly what it is, about it. And maybe some of our colleagues here might have some thoughts, but it is. And I think that that's what's kind of so interesting about it, is that we all know pregnant women should avoid cat litter, right? You know what I mean? Like, that one is so prevalent in the zeitgeist, and yet we don't really talk about CMV. And I think partly it is that there is nothing that you can do about it, right? There is no vaccine for it currently. The prevention is really aimed at not having a lot of times the mother gets infected from the previous child. So there's an increased incidence of this congenital CMV in the second or third child, because the mother gets infected by their child that's in daycare, the first child that's in daycare. So a lot of the prevention that you'll see is like avoiding kissing, avoiding sharing utensils with your, kids and things like that. And that's not super desirable, but it's also like, well, why aren't we saying that? Why are we talking about avoiding cat litter, but not saying that, maybe there are other viruses that you can contract, or again, can have reactive properties, because it's not necessarily that they contracted it for the first time. So it could have like erupted. Lori.
Hi. So I have a couple questions, but one, how do you think that new pediatric NPs can facilitate early diagnosis and intervention for CMV related hearing loss in collaboration with maybe audiologists or something? I don't know, what would we do?
Yeah, so I think the biggest take home is knowledge and education, in the prenatal phase. But for pediatric nurse practitioners, newborn hearing screening is mandated, across all states, right? So if a child does not pass that, then think of CMV, right? And think of torch infections, delayed milestones, right? This is why in your FNP courses, Lori, we're always talking about milestones in terms of watching the pediatric population. Because again, if 90% of patients or infants are asymptomatic, and yet they haven't, that population has an increased risk. 1 in 10 will become deaf. Watch for those milestones of, communication, responding to name, things like that, right? And then we'll just listen to the caregivers, because they might have some indication that something is delayed or something is sort of different neurologically as well. And so, yeah, those are kind of my tips.
Okay. And I was just wondering, because of all the disparities in access with prenatal care and early diagnoses, is this impacting outcomes for children with congenital CMV? And are there any systemic changes that you think are needed?
Yeah, that's a good question. And, and this isn't even just a US problem, this is globally, right? There is a disproportionate number of kids infected from disadvantaged backgrounds or in other countries as well. So I think awareness is big, vaccine is huge, and hopefully that will be on the market. It's in phase 2 with Moderna right now. But that is, until we have a vaccine, I think we need better education about it and screening. And so I also do believe that it should be part of screening nationally, right? So there is a RUSP sort of list of recommendation of universal screening precautions that is like this big list. And it's not even on there, right? So that's the other sort of thing is legislatively encouraging states to adopt screening measures. And then I think it should be on our national RUSP too.
Thank you.
Tracy.
Thank you, Dr. Zappas, for an excellent presentation. And my questions are twofold. What can we do to advocate from a policy level to ensure all 50 states are including including this as a part of the newborn screening? I look at a couple of states that I've practiced in, for example, Arkansas. It's not even on the horizon. So what can we do as a boots on the ground effort to create advocacy and encouraging it, especially with our nurse practitioner colleagues that are in our professional organizations that we're with? That's the first question. And then second is related to somewhat of what Lori was asking in terms of competency-based education. What can we do to align this training and the resources of what you've presented and centered around the domain of population health and disability? So those are my two questions.
Well, first, that is one of the things that the National CMV Foundation is striving towards, is getting laws. And so different states, there can be members of the foundation or, just anyone really, to write legislators and try and get this screening as enacted as a law. So that's sort of the one thing that can happen there. Yeah, I mean, and you're right, it does align very well with population health, with disabilities, with disparities, with, a lot of different things. I know that since this is one of my passions is increasing awareness about CMV, that we've incorporated into our curriculum here. But I think even on maybe even a little bit of a broader context, again, talking about those torch infections, period, and that because, we don't expect every nurse practitioner that graduates to know everything out there, right? But just have some basic knowledge and the critical thinking abilities to say, hey, this kid has microcephaly. I know that that's associated with torch infections. What could this potentially be? And encourage workups and screening. So I think that, again, just that sort of base knowledge about an umbrella of different disorders and what can happen congenitally is important.
And my last recommendation, I mentioned AWAN, and that is an organization that will be a great platform. And their annual meeting is usually in between June and July to submit an abstract for. And the second one is for CANS, Scientific Association, that will be very appropriate. Their participants or members would be more than happy to hear this information, and that is a way to disseminate it on a national level. So thank you for sharing.
Great, thank you.
I think we have time for one last question. Oh,
Just broad stroke, I know about CMV from way back because I worked in a residential program for infants and toddlers, and many of them were immune compromised, not because
Yeah.
they were HIV, but just because of where they were neglected, they were experiencing all of that, so they would come into our setting. And the nurses were the ones who taught me about CMV because I had no idea what it was. But from a broader perspective, in terms of the collaboration between nurse practitioners and social workers, what might be the kind of efforts that we could imagine
Yeah.
embarking on as sister professions,
Yeah.
right? What would be the role, of social workers in this domain? How could we help support, what you're advocating for, so that we get a kind of a national, map out there that looks more uniform.
Yeah,
with every
right.
state addressing it.
Right. Well, the first thing that comes to mind is advocacy, right? Social workers are very good at advocating for things and driving change. And so I think that would be a nice way for us to connect on that. And yeah, and then just educating families, about it, educating women about it. Again, it doesn't, even broader, right? We're talking about the teratogenic effects, but for people that are immunocompromised, it is, it can be that pizza pie eye
Yeah.
can definitely happen, and it can lead to blindness and things like that. So I think education and advocacy is really where we can align as professions.
I would argue that in behavioral sciences, one of the things that we see in the kids that we work with and populations we work with is a lot of disruptive behavior issues, and a fair number of those are connected to hearing loss and the fact that kids can't understand, and when they can't understand and their language skills are limited, they might manifest behaviors that are disruptive, right? So I'm just thinking that that's another way by which social workers could sort of embark on helping to understand the history or what was going on in this family and whether there was some kind of vulnerability.
I like that. That's a really good point, because it is associated with neuromuscular sort of cerebral palsy, but even intellectual disability, attention deficit, and so there is some sort of broader things of like, oh yeah, if this child is acting out, maybe it's because they can't hear very well, get a screen, right now we screen at 0 and then we screen again at 4 years, right? 0, like newborn hearing screen, and then prior to school. So yes, having other eyes and ears out there looking at our kids and saying, hey, this could be hearing loss, or this could be, something else. And let's get evaluated is a really great idea.
Well, thank you
Thank
so
you.
much for such an
Thank
interesting
you.
talk, and let's give a round of applause to Dr. Zappas. Yes. Thank you,
everyone.
and
Thank you.
just a quick reminder to those of you who are on the Zoom and in the room, we have unexpectedly two more presentations this month, which initially Dr. Zappas was going to be our capstone, so to speak, but now we actually have a panel discussion about the future of the social work profession in the next 4 years as we have an administration change and beginning a dialogue about that. That will be online next week on Tuesday at this time. It's going to be a Zoom webinar style, so sign up for that online. It's not going to have an in-person version of that because we are out of session. But then on Thursday, we actually are having an in-person talk. We've got some colleagues from out of town who are meeting with Dr. Carl Castro, and so we'll be having a presentation there, and I'm blanking on the title, so forgive me, but there is going to be one on Thursday of next week, which is the December 12th, which is not our typical time, or typical day, but it will be the typical time and the typical room. Thanks everyone for coming, and thanks for coming so consistently this semester. All right,
Bye,
thank you.
thank you.
They said too, Sarah